Hi, I'm Harlan Krumholz, Editor-in-Chief of JACC and Professor of Medicine at Yale University. I'm here with the amazing Ania Jastreboff, who I consider to be one of the leaders in the world in obesity medicine. Ania, I got some quick hits for you. Let me ask you this. Is obesity a disease? Should we be thinking of it as a disease?
Absolutely. Obesity is a disease like any other chronic complex disease, and that's exactly how we should be treating it. We need to target the biology of obesity. We need to discuss the biology with our patients. This is so key. It really releases our patients from the shame and the blame that they've so unfairly faced for so many years. So this is a key point.
Well, what convinced you it was a disease? I mean, a lot of people think, this is just about eating better, exercising more. It's just about willpower. What convinced you that we should be medicalizing obesity? I mean, there's still a lot of people who don't buy into this idea of obesity as a disease.
I mean, I think that for years we asked our patients to do something that we would never ask for other diseases. So we asked our patients basically to treat their own disease. We said, eat less and move more. Now, let me ask you, if you see a patient with high blood pressure, do you say, well, your blood pressure is really high, you need to go home and eat less salt?
Yes,
And
right. We'd
you
say
know,
that.
well, okay, fine. So you do say that. So I'm not saying that it's not important to eat a healthy diet and to exercise. Of course it is, but that's not the only treatment. Just like the only treatment for hypertension is not a DASH diet. But it really does begin. I mean, everything is about the patient and everything is about what the patients teach us and what my patients have taught me. And really, what it was is that we were advising patients to eat less and move more, or eat more healthfully and move more. And yet, that was not working for many people. And again, the reason why I come back to other diseases is because when we see a patient with diabetes, that's not the only thing that we recommend. We recommend healthy diet and exercise in the context of giving them medications that can help treat that biology. So, in terms of obesity, what's actually happening is that our body developed this amazing biology, and that biology was created so that we could store energy. And we store energy as fat. So that's a great thing. If we could not store energy, we would die. We would die as a species. So we created this way to defend energy, to defend energy stores, and specifically to defend fat mass. So we call it the defended fat mass, or set point. And so what happens is that there's all these hormones that communicate to our brain, this is how much energy you should store. So that's wonderful. And we have this amazing biology. And so one might say, well, if we have this amazing biology, then why in the world do so many people have obesity? It's half of Americans. It's a quarter of the world population. Why is that? And half of Americans did not wake up one morning and decide to have the disease of obesity. And the answer is our obesogenic environment. So, what happened is that within the environment that we live in, that is filled with ultra processed food, all this stress, lack of physical activity, lack of sleep, what's happened is on a population level, our defended fat mass has increased. And so that's why on a population level, there's so much obesity. So that tells us two really important things. The first thing is we have to keep working on our environment. We cannot continue to have this obesogenic environment that basically creates more chronic diseases, including obesity. And the second thing it tells us, though, is that for the people who already have obesity, who have these changes in terms of how much fat how much fat their brain tells their body to store, in terms of those people who already have the disease of obesity, we have to provide them or offer them additional treatments, and those treatments include medications or surgery. Now, in terms of medications, what we think is they actually work on that defended fat mass. So the medications, most of the medications that we have, they actually work in the brain. There are receptors in the brain for these various hormonal pathways, and that is actually how we think that they work. Um, and now, to answer your question about what about the research that I had done earlier on in my career, so that was based on the fact that I saw my patients coming in and we would recommend certain things. And yet, they were still craving these foods that were so highly desirable, and patients were wanting to, even if they were adhering to, let's say, eating salads with lean protein and exercising, they would still potentially eat these ultra processed, very delicious foods that were high in sugar and high in fat, especially in stressful situations, when life just became life. And so I wanted to really start to understand, well, does the brain find these foods to be more desirable? Do we crave these foods more? And if somebody has obesity, then potentially are there changes that are occurring in the brain that can lead people to actually want those types of foods more? So we looked at responses to people's favorite foods. We looked at responses to food pictures. We looked at responses to actually ingesting glucose and fructose. So obviously, our brain really likes sweet things. And there are differences in how our brains respond if we have obesity or if we don't have obesity. And so this question arose of, well, are these changes potentially reversible? And we don't know. Right now, what we know is that for a medication to work, we need to continue that medication. And that's exactly what we see in other diseases. So if you stop an antihypertensive, your blood pressure goes back up. If you stop an anti-obesity medication, your weight goes back up. And we think that's because your defended fat mass goes back up when the medication is stopped. So I think a lot more research has to be done looking at that. But so far, what we're seeing is very similar to other chronic complex diseases.
That's great. Ania, I want to talk about terminology. Obese people, morbidly obese people. I'm hearing more and more that these aren't words that we're using anymore. We're talking about people with obesity. We're talking about obesity as a disease, not as something that identifies people. Help our audience understand what's the way that we're talking about obesity today when we refer to our patients.
Yeah, great question, Harlan. And I think such an important one. Language is so important, and the words that we use are so important. So we really strive to use person first or patient first language. So to not define the person by a disease, which is so critical. That's not who we are. And so using language such as a person with obesity, a patient with obesity, an individual with obesity, rather than an obese person, in the same way that we would
Let
also
alone
not.
a morbidly obese person, which just really feels
Yeah,
pejorative and derogative, right?
exactly. What else do we say? I mean, morbid, that's, yeah. What other disease would we say? Morbid cancer? So really we need to look at how we use these words in the context of other diseases as well, in the same way that we would say a person with diabetes rather than a diabetic. So I think it's really critical. It's really important. We need to ask our patients what words they also feel comfortable with. And so some patients start out and they're more comfortable in terms of talking about weight or carrying extra weight, before we get to the understanding that, obesity is a disease and we will help take care of that disease. We'll give them solutions, and help them have options in terms of how to treat that disease. But we need to meet our patients where they are and make sure that they feel comfortable and they don't feel judged. And certainly they don't feel like they're defined by their disease.
That's great. I mean, recognizing the stigma, trying to eliminate it, elevating patients, treating them with dignity. Thank you so much. I think that this is such a helpful way to talk about it. Thank you.
And I'll say one other thing, I think compassionate care is important for all patients, but especially for patients with obesity because they have faced so much shame and blame. It's completely unfair. And so we really need to be especially compassionate with our patients with obesity.
That's a really great point. Ania, here's a quick question. Why should cardiologists care about obesity? I mean, is this obesity something that every cardiologist should know about, should be engaged in, should be treating, or is this really outside the realm of cardiology?
Yes. The answer.
Of course, I agree with you. I agree with you.
Yes. So absolutely. If we think about diseases like heart disease, HFpEF, all these different, or even stroke, all these diseases are really related to obesity. There's over 200 obesity-related diseases, in fact. And the question is, why are we treating all these downstream diseases rather than treating the primary cause, if not main contributor to all of these other diseases? I think that obesity is so unique because really, if we can treat it effectively, which I think now we have effective and safe treatments, if we can treat it effectively, we can prevent, mitigate, treat all of these other diseases. And yes, will there be individuals who do not have obesity who have these diseases? Absolutely. But we can certainly capture a large majority or a majority of patients who have these diseases by treating obesity effectively and
I
safely.
mean, now we know for sure it's an effective treatment for secondary prevention in people living with obesity. We know that it's an effective treatment for patients with heart failure and preserved ejection fraction, as you suggest. And it's likely to be shown to have an increased number of benefits over time. It can lower blood pressure. It can reduce hyperlipidemia and dyslipidemia, can modify that. It lowers inflammation. We in cardiology need to be alert to this. And we need to seize this opportunity to reduce risk. Again, in concert with shared decision-making with our patients, according to their preferences, values, and goals. But it's a terrific opportunity. And Ania, I really appreciate you endorsing this strongly. I will tell you that at JACC, we are firmly committed to publishing evidence, guidances, and helping to raise awareness within our field about the opportunity we have now to help treat obesity and help our patients. And of course, you're going to be helping us, which is terrific.
Yeah, I mean, and I think it's wonderful. I think it's wonderful that JACC is leading this effort and this obesity revolution. Patients listen to their cardiologists. Not to say that they don't listen to their endocrinologists, but they really listen to their cardiologists. They understand the importance of heart health. And so I think cardiologists becoming involved and taking a lead in really treating obesity in the patients that they see is really going to make a tremendous difference in terms of the health of so many people.
Great. Look, Ania, here's a question people have. Is there such thing as healthy obesity? I mean, are there people with obesity whose blood pressure is fine, whose lipids are fine, who we really shouldn't be bothering about cardiovascular risk reduction because, their other risk factors are not perturbed, they're not out of whack, they're not high. Is there healthy obesity?
So I think there's a few things in there to think about. First of all, your question, well, is there really healthy obesity? So some patients may carry extra weight, and at least by the BMI definition, which isn't a great definition, right? BMI is a screening tool. They meet the definition of obesity that we have today, and they may not have those metabolic sequelae that you're speaking about, but they may encounter other medical or psychological or psychosocial sequelae. They may have knee pain, or they may have hip pain, or they may have obstructive sleep apnea, or they may have, they may have faced shame and blame or been discriminated against. So there's many, many other things that patients with obesity face that can impact anything from their mental health to their physical function and in terms of their metabolic health. So that's the first thing.
But let me just ask you this though, because I think this is key to this question, which is, are the adverse effects, the increased risks associated with obesity, all mediated through risk factors that we can discern, like lipids and blood pressure and inflammation? Or is it that obesity itself can, have other pathways? And so for us, it's not letting people off the hook if the traditional risk factors look in line. If they're living with obesity, they're still likely at high risk, let alone for the 200 other conditions associated with obesity, but for the cardiovascular risks. What do we know about that?
Well, I mean, again, I think in terms of having obesity, just because you don't have the downstream effects yet, right, whether it's on the heart or metabolic effects or anything else, doesn't mean that you're not at higher risk for developing them down the road. So, so let's say that you're a person who's 20 years old and has obesity and does not have hypertension. It does not mean that when you are 40, that obesity that you've had for 20 years doesn't predispose you to then develop hypertension when you're 40. Same thing with knee pain or any other obesity-related disease. So I think we need to consider what is the health benefit, the long-term health benefit over a lifetime for that individual, and treating early rather than waiting until those downstream negative or those downstream diseases develop.
But I'm going to push you. Are there independent effects of obesity on cardiovascular risk, or are they all mediated through these blood pressure, dyslipidemia. I mean, I think this has been controversial in the past.
You mean in terms of the fat tissue itself and what it, I mean, again, obesity is considered to be an inflammatory state. So
Hmm.
in the same way, so I'll give the example of diabetes. I'm an endocrinologist, so there you go. So when we look at dysglycemia, we're looking at dysglycemia. We're looking at glucose levels. Well, before there's dysglycemia, there's dysregulation in terms of insulin levels, right? So insulin levels initially go up, they're much higher. You don't see any dysglycemia. But is it less normal to have these high insulin levels? I would say yes, right? Because eventually your pancreas gets tired and it can't keep up. So not only do you have high insulin levels, then your blood sugars are no longer controlled. So is there a similar model in terms of cardiovascular health or other metabolic diseases? I would say yes. And diabetes progressing to, or I would say normal glycemia progressing to prediabetes, and prediabetes in and of itself is a state of risk for micro and macrovascular disease, and then progressing to diabetes, which of course is it puts you at higher risk for all of these cardiovascular diseases. It's all a disease progression. So why not treat it early on? Why not treat it before all of these other pre-disease states occur?
Well, let me tell you my frame, and you can tell me whether or not this is right. If I think about this parallel with hypertension, it is true that there's some people with very high levels of blood pressure who never have strokes, never have heart failure, don't have renal disease, don't have downstream sequelae that we can determine. But we've been unable to determine who are these people, just like the people who smoke who may live a long life. What we know is on average it confers risk.
Yes.
And that some of that risk is mediated through different pathways, but we haven't yet figured out exactly if we can identify who is immune from the adverse effects of this, either short-term or long-term. I feel like we're in the same place with obesity, that there may be people whose profile looks good today, but we still haven't determined who exactly might live a long and healthy life despite living with obesity, when we know on average it will confer risk. And like you said, that risk is not just cardiovascular. It can be a wide range of things, including orthopedic issues and beyond cancer risks. But at least in cardiovascular, I'm not sure that we're in a place where we could safely say someone living with obesity is safe from cardiovascular disease.
Yes, I mean, I agree. And again, you can say that for any of the other 200 obesity related diseases, including certain types of cancer. So the thing is unless you can identify an individual and say, okay, and this individual has absolutely no risk for any of the 200 other obesity related diseases, but still, then wouldn't you still offer treatment? Right? There are other sequelae that aren't cardiometabolic.
And in a
And
shared decision-making model, you're laying
ex-
out the pros and
ex-
cons, and people, according to their risk values
yes.
and goals, can make decisions. But certainly we should be talking about it. Anya, here's a question for you. Some patients tell me that, look, you're starting me on this med, I'm going to be on it for my whole life. How much do they know about the safety of this med? Is there going to be something that comes up later? Because everything I've heard is positive about these meds. There's lots of people starting them. But surely there's something else here. And do people really know what happens, since you're telling me I've got to be on it my whole life, especially if we're starting people earlier in the course of the disease? What are you telling your patients, and do you have any concerns?
Yeah. So the first thing that we talk about is in terms of GLP-1 receptor agonists, they have been used for the treatment of diabetes for nearly 20 years. So we do have data in that population, and most people with diabetes do have obesity, although not everybody does. So we do have information there in terms of safety. The second thing that I say is, there's nothing in life that is all good. That just does not exist. And so, the question is, does the risk outweigh the benefit? And what we're seeing now are the benefits, and they certainly appear to be greater than the risk. Does that mean that we shouldn't continue to monitor? Of course, we should monitor. We need to do real world studies to look at the effects of these medications, because millions and millions of people are going to be taking these types of medications. So I think it's important to know that. But at this point, we're not seeing any safety signals that would discourage us from looking at these medications for obesity, as well as for many obesity-related diseases.
And I've got a scenario for you that I want to see what you think about. Look, today, the evidence is accumulating about these treatments for obesity. They're remarkable. I mean, it's an amazing win streak in cardiovascular medicine. I mean, study after study. We had SELECT, secondary prevention. We had STEP-HF and SUMMIT now showing in HFpEF and a variety of other studies that are demonstrating that these are consistent benefits across subgroups. It's lowering inflammation. It's in many ways, for at least in heart failure, is causing remodeling of the heart in very favorable ways. I published a paper in Heart that showed that it lowers blood pressure profoundly, and importantly, in patients is also modifying lipids in important ways. Here's the thing. A lot of cardiologists, I think, are thinking that obesity is not in our area and are trying to figure out what they should do. I say, if you know how to treat hypertension, if you know how to treat hyperlipidemia, if you've been helping to modify risk factors and you're thinking about the risks of your patients, then you need to gain the skills in how to use these medications. You need to have a proactive approach to offering for patients living with obesity the opportunity to have their obesity treated and their risk lowered, especially in secondary prevention and especially in HFpEF, where the evidence is, I think, without question, strong. And these are unquestionably going to be in the guidelines soon. And so we can start acting now. What do you think? I mean, where do we stand with regard to cardiologists? What are you thinking as leader in obesity medicine? There's not enough obesity medicine experts in the world to be treating all the people with obesity. So shouldn't the cardiology community be stepping up here and really leaning in to this immense opportunity to improve health?
Yes. I mean, if we think about it, at least in the United States, half of Americans have obesity. A majority of obesity treatment is coming and will continue to come from primary care providers. If a person has more complicated obesity or they're not responding to treatment or not tolerating treatment, yes, they will be referred to endocrinologists or obesity medicine experts. And we're happy to see those patients. I'm an endocrinologist. I have to say, most people with diabetes are not seen by endocrinologists. They are seen by primary care. And then we see the patients who potentially are more complicated. I think the same thing will happen in terms of obesity treatment. Having said that, though, as you said, since the evidence is really mounting in terms of cardiovascular benefit, and as you said, secondary, cardiovascular disease or event prevention, in terms of HFpEF, we have an ongoing trial looking at
sleep apnea as another risk
sleep
factor.
apnea. I know exactly. We have a trial ongoing looking at not only secondary cardiovascular event prevention, but primary prevention in those who are at higher risk. These trials are all ongoing, and some of them have already read out with really remarkable outcomes. And so I think cardiologists have this amazing opportunity. They can actually offer their patients this therapy that can that can really impact them and impact their risk and their health outcomes. If somebody feels like they don't have enough training or enough education about how to use these medications or how to treat obesity, there's many courses online. Hopefully what we're doing now is trying to play a little bit of catch up and bring obesity education into the medical schools, into residency programs, into fellowships, and really expand that. But right now, in this moment in time, what's happened is we have these highly effective tools, and now we have to make sure that those who are interested in using them have the training and the education to use them. But absolutely, I think cardiologists can make such a huge difference. And as I've said before, patients really listen to their cardiologists. And so your words carry a lot of weight, no pun intended. And really, if cardiologists start treating obesity and really start treating the core and primary contributor of all of these diseases that you're seeing, and they can help reduce the risk of a lot of these various outcomes. And that's really what you strive to do. You want to reduce risk.
And just to check one more thing, I mean, my view of this is that this isn't about weight loss, but this is about cardiometabolic health, at least as a cardiologist. I think these drugs have profound effects on cardiometabolic health. So I think they're health promoters, heart health promoters. And I don't just think of them as weight loss. It's just the weight loss is part of it. But this is about improving cardiometabolic health, lipids, blood pressure, inflammation goes down. I mean, this has multiple benefits with regard to cardiometabolic health.
Yes. And I'll just extend it and say, yes, absolutely cardiometabolic health, but overall health in terms of how our patients are doing. So as a cardiologist, I know that your focus is on cardiometabolic health, and the heart is extremely important. I don't dispute that at all, but it's overall health. And the amazing thing is, once you help a person, with their obesity, and their life is transformed, it's like you never want to do anything else. At least that's what happened with me. I helped one person, and after that, I was like, "Yep, I'm doing nothing else.
So
This
I
is
think
it."
cardiologists should want to dig in. By the way, I didn't even mention kidney health. We've also got trials, the flow trial,
Yes.
and we published sub-studies of that in JACC. That again, kidney health. So, but you're tapping into something important. I think cardiologists will enjoy the
Mm.
opportunity to use these meds because unlike antihypertensives, people focus on their number, whether blood pressures, but this actually is people lose weight. Many people are grateful, feel good, and for the first time in their life, they're able to gain control over something that despite the fact they've tried and tried and tried, have not been able to, and now with the assistance of these medications can do so.
And I think the great thing about treating obesity and helping patients with obesity is, as you said, they're not feeling their blood pressure in the same way that when I treat someone with diabetes, unless their blood sugars are very high, they don't feel their blood sugars, right? Unless, again, they're very high and then you decrease the nocturia or whatever. But with this, they know they feel the changes very quickly, and I think it really helps with adherence too.
It's fun to treat these patients with these meds because the results are so dramatic, helpful, and the patients are so appreciative. I'm just tapping into this because I think
Yeah,
cardiologists should know we can improve people's cardiometabolic health, but in this case, people are having tangible benefits in many ways.
yeah,
And it's, I mean, among everything else, it's fun to be helping people so profoundly.
yeah. I mean, I think there's a lot of um, gratitude. I mean, people's lives are just changed, and I feel very honored that patients would trust me with their lives in this way and with their health. And so I feel very grateful that now we can actually truly help them. And yeah, I think cardiologists will. Again, I think if you treat one person, you help them in this way, it's transformative.
A lot of cardiologists are just beginning to start to use these medications. You and I have talked at length about the importance of titrating up slowly in order to avoid the adverse effects, which can accrue because people just move too fast. Can you just give some quick hints? What are some special hints that you can share, secrets that you can share with cardiologists about the way to use these medications as they begin to integrate these into their practices?
Sure, it's my pleasure. And they're not secrets, they're all tools that we should be using. So the most important thing is to know that most of the side effects that occur are gastrointestinal, and they mainly occur during dose escalation. They're transient and during dose escalation. So that's key, because that during dose escalation tells us something. And what it tells us is that we can decrease the side effects by going up more slowly. So if you remember nothing else, it's start low and go slow. Always start with the lowest dose when you start one of these medications in a patient who's not taking one of these medications, who hasn't taken one of these medications previously, and then go up slowly. There's nothing that says you have to go up once a month. That is not a requirement. And most of my patients, we do not go up once a month. So, the parallel would be if you start someone on an antihypertensive, would you automatically always go to the highest dose, right? If they have, borderline hypertension, you're not going to use the highest dose. You're going to go up slowly and tailor it to what the patient needs. And it's the same thing for these medications. We need to start low, go slow, and tailor to the dose that the patient needs. So let me give you an example. So let's say that you have a patient and you start on one of these medications and they do okay with the first dose. And then, 6 or 8 weeks later, you go up to the second dose and now they're having nausea. Well, if that nausea is mild, you can see how they do for another, 4 to 8 weeks. If that nausea is moderate, go down on the dose. Let their body have extra time to adjust. If and when the nausea abates, then you go up on the dose. And basically, in this way, if you don't go up, if a patient is having nausea, they're not going to have vomiting. Vomiting occurs if we go up too quickly or if a patient starts on a higher dose. inadvertently rather than on the lowest dose. So start low, go slow, and you do not have to go up once a month. Now, there are also mitigation strategies that our patients can employ. So we can help them by going up slowly. Our patients can help us with a few things. One, if a patient is having side effects, invite them to tell you about those side effects. So before they even start on the medicine, say, look, if you have side effects, come tell me. I'm not going to take the medicine away. We're going to work through it together. We're going to figure out how to help you. The next thing is they can do certain things in terms of their eating. So one, they can anticipate that they're going to get full earlier. So eating smaller amounts. The next thing is they can start to notice which foods may exacerbate their symptoms. So let's say that they eat egg salad, and every time they eat egg salad, they have diarrhea. So during the dose escalation, maybe eat less egg salad. It's high in fat, and maybe that's what is exacerbating their symptoms. And then the last thing is they may not be able to eat as much in any one sitting. So eating more frequently, but smaller amounts is also helpful. So again, those mitigation strategies for patients are not eating past the point of fullness, eating more frequently but smaller amounts, and then noticing which foods may exacerbate their symptoms. And I think if you implement the strategies of going up slowly, not once a month, but what the patient needs, and then having the patient implement some of those strategies and then let you know if they're having side effects, those things work really, really well. And patients really tolerate these medications very, very well clinically. In clinical trials, we go up as the trial says, right? They're protocolized. And that's because the FDA needs 52 weeks on the treatment dose. And so they have to dose escalate during a certain time period to be able to make sure that the FDA has the information that they need in these regulatory trials. But in clinical practice, just as we, don't dose escalate necessarily for other agents, within a certain calendar or a certain framing, in the same way, we can really tailor this to what the patient needs.
And is there any concern about malnutrition? People stop eating very much. Are you giving people vitamins, or are you giving them any advice about their diets?
Yeah, so in terms of eating, and in terms of eating and physical activity, I'm so glad you asked about this. So first, I'll just say there's no medicine out there that we've created so far that can help people eat more healthfully or move more. That does not exist yet. Having said that, I think some of these medications down the road will figure out how they may affect food preference. We already know with these medications that during dose escalation, the foods that tend to cause more side effects are things like fatty foods. So people may prefer not to eat those during the weight reduction phase. Once they hit plateau, they're able to tolerate those foods much better. And we can talk about that too, because that's actually really important. So we can come back to that. In terms of recommendations that I give to patients when they start these medications, there's a couple of key things. The first thing is in terms of their eating, they are going to be eating less during the weight reduction phase. So prioritizing protein, and I usually recommend about 1 gram per kilogram of protein. Now, if you work with a dietitian, they can work with your patients on that. There's also many apps that your patients can use, like MyFitnessPal or other things that are free and can help track how much they're eating in terms of protein intake. So that's really helpful. So lean protein intake, about 1 gram per kg for your patients. The second thing is I say prioritize fruits and vegetables as much as you can. And the reason I say this in terms of the protein and the veggies is because they're eating smaller amounts. So if they're eating smaller amounts, it's really important to eat those things first because they're going to get full and then they won't have room for that protein or those vegetables. And the third thing that I talk about in terms of eating, or actually more importantly, drinking, is to make sure to stay well hydrated. So especially as they are in the weight reduction phase, it's so key to focus in on that. We know that thirst can also decrease, just like hunger decreases during the weight reduction phase, so can thirst. And patients can become dehydrated, or if they're having diarrhea, then they can also become dehydrated. So it's really, really important for patients not only to drink a lot of water once a day, but to take sips of water throughout the day. You can't see my glass of water, but I always have a glass of water with me no matter what, just because our kidneys are important. So I always encourage my patients to drink a lot of water and to make sure they stay well hydrated. Now, physical activity, this is really key. It's really key for our patients to also add in physical activity or movement throughout their day, and especially resistance exercise. And there's been a lot out there about muscle mass and that people lose not only fat, but muscle. Well, that is the case with any treatment for obesity, whether that is bariatric surgery or diet and exercise or these medications. People lose both fat and muscle. There are medications in development that can target losing more fat mass while preserving lean mass, but right now we don't have those medications yet. They're in development. And I always recommend to my patients, whatever movement or whatever exercise you like during your day, whether it's taking walks or anything, just add in as much as you can and try and add in some resistance exercise any way that you can do that.
That's terrific. And just to get to your point about the goal or plateau phase, what do you do for goals?
So there's two questions in that. One is targets. So we don't have really great defined targets or goals in terms of obesity treatment. What is the goal of obesity treatment? It's not a BMI of 25. BMI is a screening tool, and we're using it as a diagnostic tool, but we're not including in that fat mass or percent fat mass or any other health measures for that person, whether it's blood pressure, A1C, lipids, other obesity-related diseases, symptoms of obesity that patients may have, such as a preoccupation with food, which we tend to call food noise. So we're not accounting for any of those. And I think targets and goals for obesity treatment will include that down the line. We're not there yet, but we're certainly working on it. Now, your question about plateau. So what happens when a patient starts one of these medications, if they're responding, they start to lose weight. And what we think is happening is that their defended fat mass, or how much energy their body wants to store, is re-regulated with these medications. And it's re-regulated to a new set point, a new place. So let's pretend that you have a patient who weighs 120 pounds and they start on a medication and they decrease their weight to, let's say, 200 pounds from that 220 pounds. So they lose 20 pounds and they hit a weight plateau. If you could increase the dose of that medicine to see if the weight is further decreased, and that's usually what we do, or sometimes we add another medication. But these phases of treatment are really important. So during the weight reduction phase, that's when patients are most likely to have little food intake, because the way that I say it is that they're chasing a new defended fat mass. So as soon as they start a medicine, as soon as they start a dose, they're chasing a lower defended fat mass. And every time you increase the dose, they're chasing a new lower defended fat mass. So during that weight reduction phase, their appetite is decreased. Once a patient reaches plateau, a weight plateau, or a defended fat mass plateau, their appetite and even their cravings return, but the weight does not, as long as they continue the therapy. So this is really important for patients, because sometimes they may start a medicine and say, well, I don't really want to eat food. Like, I don't enjoy food. It's just kind of there on my plate. I could take it or leave it. It's not negative, but it's also not something positive. And it's just kind of there. And they eat a few bites of food and they're full. You want to reassure your patients. You want to reassure them that once they reach plateau, they will have cravings again. They will have hunger again, and they will have that return of enjoyment of food that they may have lost during that weight reduction phase. They'll also have the ability to eat more food. So again, during the weight reduction phase, they're eating very little. They're chasing that new defended fat mass. Once they reach plateau, their body's like, oh, I'm good. I'm where I need to be. This is exactly how much energy I should carry. So some days I can eat more and some days I'll eat less, and that's fine. So you just need to reassure your patients that it's a journey and it will change over time. And you also need to let them know this, because some patients get anxious when they get hungry again. They get anxious when they have cravings again, because they get so worried that they're going to gain back the weight.
Yeah.
So you need to just reassure them that as long as they're taking the therapies, we're going to continue to make sure that they're doing well. And if they need additional therapies, we'll add them. If they're continuing to respond well, then we'll continue that therapy. And really that reassurance and knowing where the path will take them is really key.
And I think you're raising, as we get to the end, one other important issue, which is helping to build in the right expectations for patients. So this also goes with your start low and go slow. telling people we're really going to try to get to a destination over the next year or so.
Mhm.
So don't expect that this is something we're going to give you and then you're going to get to, you know, treat your obesity and have remarkable results in the short run. This is something we're committed to. It's a chronic condition. We're going to make progress over time, and you're going to go through various phases on this journey, and we're going to be working together on this. But don't think this is going to be like I need 2 shots and I'm going to be, you know, a better place. It really is a commitment. You know, it's going to be interesting to see as these new meds come out once a month, oral, all the different kinds of meds with hands. But I think this is going to stay true no matter what comes out, which is start low, go slow, and building in the expectation that, you know, we're going to try to be in a better place a year from now. And it's
Yeah.
a journey, as you
Yeah.
said.
Yeah. And I completely agree with that. And I think, you know, one of the things that helps is to say, well, the weight did not come on overnight. It took years. It took years. And so it's not going to take us years to help you, you know, carry less weight, but it is going to take time. And that is not a bad thing. We want to do this carefully, safely. And to come back to one of your questions in terms of concern of patients not eating enough, if you do have a concern that your patient is not eating enough, because these medicines are going to get stronger and stronger and more powerful, is to say, okay, well, maybe I should decrease the dose.
Yeah.
So the way to do that is not to say eat more, because if you say to your patient, well, you need to eat more, they're going to have side effects. That's when they're going to feel nauseated. What you need to do is decrease the dose, and that allows your patient to potentially eat more food. And then you can always increase the dose. The other thing that we talk about, and we really need more data on this, we don't have data on this, is, you know, what is a physiologic rate of weight reduction? So with bariatric surgery, we don't have the luxury of slowing down weight reduction. You have bariatric surgery and then you lose weight as you lose weight. With these medications, if we titrate more slowly, the weight reduction can be more slow. So right now, because we don't have data to inform this, I usually target no more than 1% per week of weight reduction. And so I just do a really quick rate calculation and see how they're doing. And if they're losing more than 1% a week, I don't increase the dose or I de-escalate the dose. And that ensures that our patients, you know, can eat the amount of food or the amount of protein or veggies or anything that we would like them to eat, and then also potentially gives them enough energy so they can do things like exercise. So those are really, really important things. And I think we need more research to really investigate that.
And are you using vitamins?
So in terms of vitamins, you know, with bariatric surgery, there's obviously a recommendation for vitamins. And the question there is, you know, bariatric surgery, it's not all because it's malabsorptive. So
Yeah.
I think we don't know yet with these medications what you know, if there will be micronutrient deficiencies. So I think we have to wait for that type of
And what
data.
are you doing? What are you doing now in practice?
In general, if a patient asks and they are interested in taking a multivitamin, absolutely. If I take a dietary history and I don't think they're getting enough calcium or vitamin D, so patients with obesity tend to have lower vitamin D levels. You know, we live in the Northeast, so we don't get a whole lot of sun anyway, and we wear sunscreen, right? Because we don't want to have skin cancer. So a lot of patients are vitamin D deficient. So that, you know, that's something that again in a multivitamin can help that. Our patients on metformin can have B12 deficiency. So I don't counsel against taking a multivitamin. I think we need more data to really know what's going on, but I don't counsel against it.
And I want to just talk to you just quickly about this issue of people with obesity and the sort of shame and blame. You know, these patients come in having often tried thousands of different strategies, feeling that they failed. They failed to actually manage their obesity. They've struggled with it for years, and society is looking at them as failures. We've got lots of studies showing discrimination against people with obesity and a whole range of issues. You know, so you're an expert in this. You know, help us think about this. What can we as physicians be doing? How sensitive should we be to this? What are you thinking?
Yeah, I think we should be very sensitive. I think we've contributed to this as healthcare professionals. We have asked our patients to eat less and move more for years. We have blamed them for a disease that is not their fault, and we have basically asked them to self-treat. for a disease that has clear underlying biology. I think there are many things that we can do to shift the culture from shame and blame to one of compassionate care. And it's our responsibility to do so. And one of the things that we can start doing is to share the biology of obesity with our patients so that they are released from that shame and blame that they have faced their entire lives, and let them know that, look, their bodies are really smart. They're doing exactly what they were designed to do, which is to make sure that they store energy, and to store that energy is fat. And fat is not a bad thing. It's just that when we carry too much fat, that may impact our health in negative ways. And so really sharing that biology and ensuring that our patients know that we're here to help them to target that biology, and to help them treat that disease is really, really key. I
mean,
think,
this is evolution, right? I mean, look, we were prepared to deal with starvation, periods
yes,
of where food was scarce. And so actually, probably in history, having the ability to store fat was a survival characteristic. It's just that in modern society, it's turned the other way.
that's exactly right. That's exactly right. And, patients sometimes laugh and they're like, great, if there was a famine, I would survive. But that's not a good thing in this current obesogenic environment. And that's exactly right. But when you share that biology with patients, you invite them to share their own struggles, their journey. Something happens. Something,
It can release
yeah,
them, right? I mean,
it,
and it
frees.
makes sense to them. I mean, what I found is when you start talking to people about this, all of a sudden they're going like, yeah, that makes sense, because I've tried so many different things. I mean, I've never felt it was only about willpower, but I
Yeah.
felt that, my body is working against me, not enabling me to get this sustained
Yeah,
success.
exactly. And most patients, it's not that most people can't lose weight. It's that we can't keep it off. And the reason why patients can't keep it off is because their biology is so strong. We are literally engineered to hold on to energy. And so it's reassuring patients that their body is actually doing exactly what it should be doing. Again, it's just responding to this obesogenic environment. So as we've talked about previously, that means, hey, we need to work on our obesogenic environment. We cannot have this environment that is filled with ultra processed food and stress and lack of sleep and all of these other negative things. We need to work on our obesogenic environment. But at the same time, we also need to provide our patients who already have obesity with the treatments that will help target that biology. And we're going to do it together. So in the same way that we would not ask our patients to meditate to make their blood sugars normal, or meditate to make their or concentrate really hard to make their blood pressure normal, we need to do the same for obesity. We need to say, look, I'm not going to ask you to concentrate on every morsel of food that you're going to put into your mouth for the rest of your life. I'm going to give you a medicine, or I'm going to give you a treatment that is going to help target your biology. And in so doing, we're also going to be focusing on healthy food choices and physical activity, but we're going to target that biology with you.
We're going to give them the opportunity to treat it,
That's right.
again, if it's consistent with their preferences, values, and goals.
That's
But
right.
we're going to be proactive about saying we now have something that can improve your cardiometabolic health, can help you treat the obesity, and is likely to have benefits across a broad spectrum of conditions.
Yeah. And I think you raise a really good point there, with what you just said, which is that it's the opportunity. And every patient will not want, medications or surgery or additional other treatments. And that's okay. That's okay. That, it is our patients' lives and it is their choice. And we're basically here to talk about the risks of treatment, or the not risks of treatment. We're here to talk about the benefits of treatment, or not the benefits of treatment. So we're here to basically let them know that these options are here, and we're here to help them with whatever choices that they make, and we're going to support them with whatever choices that they make.
In the same way we would treat hypertension, meaning that we would say these are risks. There's a dominant benefit if you want to go to treatment. Some people still want to try lifestyle for a period of
Yes.
time, but it's
Yes.
important that we inform them so that they're making choices that where they fully understand what the opportunity is in front of them and what the issues are. The other thing for people today is cost. So, we've got to work hard to make sure that these drugs are accessible to people, and that that doesn't become a barrier. There's a proposal about Medicare now paying for these drugs for obesity. It is so important that people can make these choices without feeling that they are compromising their economic health, that this doesn't become a threat to the economic well-being of their families and themselves. And so this is just another feature of this too, that we have to be tuned into, not just writing scripts, but also understanding the context and advocating. If we've got a med that can really reduce cardiometabolic risk and improve cardiovascular health, let alone all these other benefits, we have to be proactive in making sure people have the opportunity to have this without the financial toxicity of large copays or other impediments to their access to these medications.
I agree. And I mean that the biggest thing is the patients who need these treatments the most may be the ones who actually do not have access to them. And so if we don't actively work to make this better, we're just going to increase the health disparities. And that's exactly what we don't want.
And I'll just say at JACC, as we approach this, publishing papers in this area, raising awareness, informing clinicians throughout, we also need to be focusing on the advocacy to ensure this doesn't increase disparities. It doesn't create two-tier system, doesn't create people who would markedly benefit from these medications, but have really no way to access them or can't afford them. So all of this is important together, but I'm just excited for this new era. It's a wonderful new tool, and thank you so much.
Thank you for having me.